The following is a presentation regarding current axillary lymph node surgical management for breast cancer patients. In this presentation, I will also touch upon several key studies that have paved the way for current axillary management. Many changes have been made regarding breast cancer care over fairly recent decades, including changes in axillary staging for invasive breast cancer. While landmark trials such as NSABP B04 demonstrated that there was no survival benefit to the radical mastectomy, and NSABP B06 demonstrated that there was no survival benefit to mastectomy over lumpectomy, patients in both of these studies underwent axillary lymph node dissection as part of their breast cancer treatment. In fact, all patients with invasive breast cancer were undergoing axillary lymph node dissection as part of their surgery for breast cancer treatment. Axillary lymph node dissection was used for determining the pathologic nodal status, which is important for cancer staging. During this procedure, level 1 and level 2 axillary lymph nodes are removed, and axillary lymph node dissection carried with it an increased risk of lymphedema, which could be both debilitating and disfiguring. In the mid-1990s, sentinel lymph node biopsy emerged as an alternative to axillary lymph node dissection for breast cancer patients. This technique was first described by Gould et al. In 1960 in the case of identifying lymphatic drainage in a patient with a parotid tumor. It was popularized by Cabanas et al. In the treatment of penile cancer. Dr. Morton extended the use of this technique to melanoma, and Giuliano popularized its use in breast cancer care. Sentinel lymph node biopsy offered a more minimally invasive way to stage the axilla. The idea behind this technique was that if the first lymph nodes to see breast cancer were negative for cancer, then the other lymph nodes further along the axillary chain would also likely be negative. After establishing a less invasive technique for identification of breast cancer spread to the axilla, came the question, to whom should this technique be applied? Until recently, everyone with invasive breast cancer had undergone an axillary lymph node dissection. If you had clinically palpable lymph nodes, which highly suggested that you had disease in these nodes, then these patients would undergo an axillary lymph node dissection. But there was a whole group of patients with clinically negative lymph nodes on physical examination who could potentially have underlying cancer in their nodes or be completely disease-free. And sentinel lymph node biopsy could be used to examine these lymph nodes, yet at the same time spare, potentially, these women from undergoing a larger axillary surgery in the form of an axillary lymph node dissection. NSABP B32 aimed to investigate whether or not sentinel lymph node biopsy in breast cancer patients achieves the same survival and regional control as axillary lymph node dissection for staging. The trial by Cragg et al. Enrolled 5,611 women with invasive breast cancer. All patients were clinically node negative. Patients were randomized into two groups. One group underwent sentinel lymph node biopsy and then underwent an automatic axillary lymph node dissection. These patients are represented on both graphs by the red line. The other group was one of patients who had undergone sentinel lymph node biopsy alone. These patients are represented on both graphs by the blue line. The average patient follow-up was 8 years, and as you can see from both tables, the study concluded that in breast cancer patients who are clinically node negative, that it is safe to perform sentinel lymph node biopsy and omit axillary lymph node dissection for staging of the axilla. If that sentinel lymph node biopsy is negative, no further surgery needs to be performed. Sentinel lymph node biopsy offers overall survival and disease-free survival in this cohort of patients that is equal. It also offered equal local and regional control. The next big question for axillary management was, what do we do when there is a positive lymph node found on sentinel lymph node biopsy? Specifically, the question was, does everyone with a positive lymph node found on sentinel lymph node biopsy need a completion axillary lymph node dissection? Z11, published in 2011 by Giuliano et al., addressed this question. Patients included in this cohort had clinically negative axillary exams and underwent lumpectomy, followed by whole breast radiation, as treatment for their T1 to T2 breast cancers. From May of 1999 to December of 2004, patients with 1 or 2 positive sentinel lymph nodes were randomized to axillary lymph node dissection or no further axillary treatment. Some patients went on to get systemic therapy, and all patients got whole breast tangential radiation. No difference in overall survival and no difference in disease-free survival was found between the two groups. Thus, not everyone with a positive node on sentinel lymph node biopsy needs to undergo axillary lymph node dissection. Another important step in the evolution of axillary management was addressing how we should stage the axilla after chemotherapy. If the patient had clinically positive nodes both before and after neoadjuvant chemotherapy, then there is no role for sentinel lymph node biopsy. These patients need an axillary lymph node dissection. If the patient had clinically negative lymph nodes before and after neoadjuvant chemotherapy, then a sentinel lymph node biopsy is appropriate. An axillary lymph node dissection would be performed if a positive lymph node was found on sentinel lymph node biopsy. With neoadjuvant chemotherapy, however, there was a group of patients who converted from having clinically positive lymph nodes before chemotherapy to having clinically negative lymph nodes after neoadjuvant chemotherapy. This happens about 20% of the time in ER and or PR positive cancers. It happens 50% of the time in triple-negative breast cancers, and this happens approximately 65% of the time in HER2-positive cancers. The question at hand was, could we safely identify these patients with an extraordinary response to chemotherapy via a sentinel lymph node biopsy so that we could spare them an axillary lymph node dissection? 3 trials, Z1071, Sentina, and SNFNAC, all looked at the false negative rate of sentinel lymph node biopsy for clinically node-positive patients who converted to clinically node-negative patients after undergoing chemotherapy neoadjuvantly. The goal was to identify techniques that would bring the false negative rate of sentinel lymph node biopsy to less than 10%. The take-home message from all of these 3 studies is that you can use sentinel lymph node biopsy to stage the axilla after neoadjuvant chemotherapy, but you have to select the correct patients in order to do this safely. Also, there are certain techniques that need to be employed in order to decrease the false negative rate. Sentinel lymph node biopsy is an appropriate choice for staging the axilla in patients who were clinically N1 prior to neoadjuvant chemotherapy and now have clinically N0 disease after neoadjuvant chemotherapy. Patients with suspicious supraclavicular lymph nodes, matted axillary lymph nodes, internal mammary lymph nodes, all need to be excluded from undergoing sentinel lymph node biopsy. Regarding surgical techniques, the use of dual tracer, which includes blue dye in the form of isosulfan blue or methylene blue, and a radioactive isotope, decreases the false negative rate during sentinel lymph node biopsy. Performing a targeted axillary dissection, where the biopsy-proven positive lymph node is clipped prior to undergoing neoadjuvant chemotherapy, and then targeted and removed during the sentinel lymph node biopsy, greatly decreases the false negative rate to less than 10%. The false negative rate was also lowered by examination of axillary lymph node pathology specimens with IHC. Additionally, the false negative rate decreases as the number of lymph nodes identified on sentinel lymph node biopsy increases. Unfortunately, this is not something that we as surgeons have control over, as we don't end up cherry-picking lymph nodes to remove. We only remove the lymph nodes that were identified by sentinel lymph node biopsy technique. If there are 3 sentinel nodes removed during sentinel lymph node biopsy, however, the false negative rate drops to below 10%. Current standard of care with clinically N1 patients who convert to clinically N0 after undergoing neoadjuvant chemotherapy and get sentinel lymph node biopsy would be for patients to undergo axillary lymph node dissection if they are found to have one or more positive lymph nodes on that sentinel lymph node biopsy. These patients would need no further dissection if they have a negative sentinel lymph node biopsy. While management of the axilla has changed much in the last 30 years, there could be additional changes in management in the foreseeable future. The focus of this presentation was surgical management of the axilla. However, changes in radiation therapy and its application in the setting of axillary disease is also evolving. Alliance 011202 and NSABP B51 are two trials that could impact future axillary management decisions. Alliance 011202 is a randomized phase 3 clinical trial that looks at women who have clinically N1 disease that convert to clinically N0 disease after undergoing neoadjuvant chemotherapy, and who have positive disease noted during their sentinel lymph node biopsy. While the standard of care is for these women to get an axillary lymph node dissection and radiation, this trial asks if axillary lymph node dissection can be omitted. NSABP B51 is a randomized phase 3 clinical trial that is currently looking at whether or not radiation, which is currently the standard of care for patients with positive disease in the axilla, even when there is a negative sentinel lymph node biopsy after chemotherapy, need to undergo radiation, or if this can be omitted. Thank you.